From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, everyone. This is Paul Bryson. I'm the director of the Cleveland Clinic Voice Center and the web editor for JAMA Oto. I'm excited today to be joined by Dr. Garret Choby, Associate Professor of Otolaryngology, Head and Neck Surgery, and skull-based surgeon from the University of Pittsburgh Medical Center. A little background, both Dr. Choby and I are from Western Pennsylvania, and it's always a special treat to get to interview a colleague who has roots where I am from as well. So welcome to the podcast, Dr. Choby.
It's a pleasure to be here, and the Pittsburgh roots run deep, so thanks for having me.
Well, today we have a pretty exciting topic. You recently composed a viewpoint for the journal talking about advances in image guidance for endonasal skull-based surgery. And specifically, there was an article that has come out recently looking at sort of a new platform or protocol for image guidance in this surgery. And we'll just jump right in. I was hoping if you could just kind of set the stage for the listener. What is image guidance like today? And then we'll take a deeper dive into this article and then just some of the implications.
Yeah, so image guidance has become really an integral part of the majority of what we do in the nose and the skull base. Historically, one of the main challenges for trainees and early faculty members was sort of translating that two-dimensional spatial awareness of the nose and the skull base and the sinuses into three-dimensional awareness, which is really what you need for surgery. So image guidance was a tool to sort of translate that so you can see in three dimensions, in coronal and axial and sagittal, where you are within the paranasal sinuses and cranial base, utilizing sort of a computer algorithm based on that patient's anatomy.
One of the key features of this too is, aside from, really the great pictures that you get when you're passing instruments and doing surgery, is that it's still a tool, right? And when we talk about surgical awareness and safety, we can't over-rely on the technology. Is that correct?
Yeah, it's a great point. I tell my trainees on a daily basis that you should trust the navigation system as far as you can throw it. In other words, computer navigation is never a substitute for a thorough anatomic knowledge. And we always operate anatomically regardless of navigation. We identify our critical landmarks based on, surgical technique and the anatomy. And then we secondarily confirm them with navigation when needed. But certainly if you rely too much on navigation, you're going to get yourself into trouble and sort of go beyond the boundaries of where you ought to be in the nose or the cranial base by relying on technology, which quite honestly can be flawed.
So, from where we're at right now, we will get CT scans, MRIs, there's a registration process. Walk me through a little bit of that. Like, how do you know that you got everything registered? How do you try to ensure accuracy to the highest level as you can?
Right. So in most endoscopic endonasal procedures, at least from the sinus perspective, we typically will use electromagnetic tracking devices. What that relies on most commonly is a fine-cut CT scan, usually obtained in the axial images. We typically like that to be about 1 millimeter slice thickness or less in order to get an accurate registration. And that will then rely on a surface registration. So we'll use an electromagnetic track probe to carefully and lightly trace over the patient's skin surface, which will be registered to the patient's CT scan and allow for that navigation field to be created. Now, in that electromagnetic or EM track navigation, there's typically a panel below the patient, which will sort of send up the EM waves, and there's a tracker on the patient forehead, which then you can register instruments onto and utilize them in the nose based on that surface registration. Alternatively, most of our neurosurgical colleagues prefer an optical tracking system or an OT tracking system. This relies on an overhead camera that optically tracks the instrument as it comes into the field. This is used for a couple of different reasons. Number one, they typically will place the patients in head pins for cranial procedures, and using an electromagnetic tracked field with a metal in that frame system is not very sustainable. However, both these have potential issues. With an optical tracking system, it's constantly a battle because between that camera head and your instrument, things get in the way, you can't see well, your camera's in the way. So oftentimes in the nose, you got to put the tracker in, then take the camera out for it to see where it is. And it's less than ideal. all these systems are prone to potential registration error as well. If, the patient wore a mask during the CT scan, the nose compressed a little bit and things aren't always perfect. So they're prone to accuracy issues from time to time as well.
Well, I appreciate that review and explanation. Let's dive into this article. So this is an article by Bartholomew and colleagues. Walk us through this. It seems like a different approach and a different way to do image guidance.
Yes, so this is an interesting article. It's sort of a concept in progress, I would say. It's something they've done at their institution. We'll go through it a bit here. And they've tried it in a patient as well, although admittedly it's not available for primetime use, outside of this particular setting. But the impetus behind this really is to look into, is there a way to do a trackerless navigation system? So instead of sort of bringing an instrument to the field and registering it and relying on your EM or your OT registration, this was sort of a newly developed technology that allows them to navigate in the nose and sinuses without using a tracker. So they created this system, which they termed a 3D simultaneous localization and mapping, or they call it SLAM, kind of a SLAM algorithm, which relies on the 3D endoscope in the nose in creating a surface map sort of registration of the anatomy around them, allowing them to navigate the area without having a tracker instrument.
Yeah, and it seems like one potential advantage would be that you don't have that competition between the overhead camera and the under-the-table EM process, if you will. What are the other benefits and downsides to the SLAM technology?
The other potential benefit in what they've done, which is pretty fascinating, is with this system, they've allowed themselves to overlay their endoscopic image with the 3D anatomy around it. So what they can do is essentially with the endoscopic image on the screen, they can sort of overlay the deeper tissue structure. So for instance, if they're operating in the sella or the suprasellar space, it overlays a 3D image with the carotid artery and the optic nerves behind it, with an attempt to give the operator some semblance of 3D anatomy even beyond where you're operating, which of course is very valuable information to know, but especially for trainees who are struggling maybe to get that 2D into 3D translation, it really allows them to get that model in their head and perhaps even speed up their learning curve a little bit, which is a pretty nice feature that's not really applicable to most of our systems in current press.
It's very interesting. Aside from, sort of this use case in the skull base, are you aware of this technology and other sort of endoscopic surgical platforms? I'm not aware, but I was curious if there's other uses of this SLAM.
I haven't heard about it for other utilizations, but certainly you could see a similar thing being available for, say, intracranial work being done endoscopically, transcranially. I could see that being a potential application, although it seems like it mostly relies on some spatial features. So the beauty of the nose and sinus is you've got air, space, followed by bone and tissue. So it seems to rely on that a little bit to generate the algorithm, but certainly you could see obviously some applicability elsewhere in the body as well.
As you said earlier, this is almost like a spec paper. It's been used in one patient, not certainly at scale yet. What do you think the future holds for this sort of technology or, skull-based surgery and image guidance in general? Is this sort of the beginning, or do you see an advancement of this technology?
Yeah, I think there's going to be advancements. Certainly, image navigation has been an area that's advanced a lot in the past 10 to 12 to 15 years. And certainly from an industry standpoint, it's a great point of emphasis. It's something that surgeons really like. I think we've come to, in a certain sense, rely on it for certain cases. I would say that in most institutions, you probably wouldn't do an endoscopic cranial-based case without having navigation. So it's used pretty frequently. And there's been some interest in our current systems to apply that overlay in 3D technology. So the interest is definitely out there, but the added benefit of a system like this is having no tracker. So you eliminate all that annoying nuance of the camera seeing your instrument and the plate below sending up EM waves and making sure you're in the right spot for it to see it. By eliminating those things, it kind of makes a fairly slick system. And I think it'd be of great interest to people moving forward.
Now, I appreciate that perspective. I mean, I can recall cases on call as a resident trying to get things registered and having trouble and trying to move the head and the instrumentation around to accurately get the person positioned or registered or the registration complete. So that point is well taken.
Totally. And the other potential benefit of a system like this is, as you think about, resident and fellow training and education, we've really moved away from the old system of, you see one, do one, teach one. So you watch somebody operate the nose and maybe you dabble and you kind of figure it out. Whereas, training models are becoming more and more important in all kinds of surgery, but including endonasal surgery as well. Some of the models that are currently available are not the most high fidelity models. So they're kind of tough to simulate, things like blood in your field or visualization. But a system like this sort of gives you a secondary benefit of a better understanding of the surrounding anatomy and maybe giving the trainee more confidence and, to be quite honest, the supervising surgeon more confidence as well to what someone and let them progress through a surgery. So certainly there might be some benefit there as well for gaining that surgical and anatomic understanding for a trainee.
Well, I really appreciate your time and your perspective today. And before we wrap up, any other take-home points or things that you want to highlight?
Yeah, I would just highlight again, like I talked about earlier, that although image navigation is an awesome technology, we all use it quite a bit. It certainly is not a substitute for a thorough anatomic knowledge. And as I was taught as a trainee, anatomy is the basic science of surgery. So don't substitute it with technology for a variety of reasons. That being said, there's a lot of great technology out there, and it's a field that continues to evolve. And things like this SLAM algorithm-based technology has pretty cool implications for the future.
Well, Dr. Choby, I really appreciate you coming on the podcast and look forward to more and continued contributions from you and your team. And it was great to talk with you today.
You too, Dr. Bryson. It was really a pleasure.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.